Well, good evening to everyone joining us from India, and good morning to those of you who, like me, are in the US. I'm delighted to be able to speak to you today. In my role as a genetic counselor and the Director of Medical Education at Oncocyte, I speak with many oncology healthcare providers across various specialties about the technologies and the tests that we're developing and actively offering at Oncocyte. At Oncocyte, our mission is to offer tests that address critical decision points across the lung cancer care continuum. And I'm very excited to speak with you today about the Determinar X test, which provides information to enable treatment decisions in the early stages of non-small cell lung cancer. So today I'd like to start by addressing the clinical need for accurate assessment of recurrence risk in early stage non-small cell lung cancer, why this has been difficult to do in the past, but why it's critical for the most favorable patient outcomes. I'll then introduce you to the Determinar X test, as well as the data supporting it as both a prognostic and a treatment stratification test. I also have a couple of case studies to present, and then would love to address any questions that you have. So I'll start with a patient story, since ultimately we do what we do so we can improve cancer care for patients. This is Ms. L. That's not her real initial, but we'll call her Ms. L. Ms. L is a 53-year-old female who first presented with cough. She lived in Asia and was seen at a concierge medical practice where they checked her tumor markers, and she underwent a full body CT. She was found to have a 3-centimeter mass in her left upper lobe. Ms. L was otherwise healthy. She took multivitamins only. She never smoked. And so she went to UCSF for surgery and had a full mediastinal lymph node dissection. Ms. L was, by all clinical and pathological features, relatively low risk. She had no positive lymph nodes and was staged as stage 1B. She had none of the features that the NCCN notes to be high risk, and we'll talk about those more later. But essentially, she had a small tumor with no visceral pleural involvement, no vascular invasion, and her cancer was well differentiated. Unfortunately, only 6 months after her surgery, Ms. LCT revealed a mediastinal lymph node mass, which was confirmed by PET. And this unfortunate outcome is all too common in non-small cell lung cancer. A patient with very early stage disease has presumably curative surgery, but then recurs, this time with more advanced disease that is very difficult to treat. Lung cancer is the #1 cancer killer in the world. Here in the US, more than 40,000 patients are diagnosed with non-squamous non-small cell lung cancer annually. And unlike other cancers like breast cancer, when an early stage diagnosis results in early surgery and often good outcomes, 30 to 50% of patients with early stage non-small cell lung cancer will experience a recurrence after surgery. Lung cancer screening and early diagnosis is not a complete solution because, in fact, many of these patients with an early stage diagnosis are actually harboring occult distant metastases, meaning the disease has already progressed, but we aren't able to detect these very small and distant metastases at the time of surgery. Ms. L's story is not all that unique. When we look at the pattern of recurrence, this is a study of over 1,500 patients who underwent a resection for early stage lung cancer. Most of these patients recur within the first year, just like Ms. L. You can see that first peak at about the 9-month point. And when we look at the root cause of recurrence, we don't see many local recurrence events or new primary cancer. Most of these recurrence events are in fact due to distant metastases that are not detected at the time of surgery. So really, these are patients that have an early stage diagnosis, but are harboring metastatic disease at the time of surgery and need further treatment beyond just surgery. There have been incredible advances in understanding predictive biomarkers in non-small cell lung cancer. But these biomarkers are all for targeted therapies that thus far have really been indicated for later stage disease. So EGFR, ALK, BRAF, ROS1, RET, MET, etc. These are biomarkers that can lead to targeted treatment, but these treatments have thus far been reserved for late stage disease. Dr. David Gandera, a world-renowned medical oncologist and lung cancer specialist, has described this as the biomarker paradox in lung cancer. And the paradox here is that the potential for cure or long-term survival is lowest in late-stage disease, where we have the most biomarker-driven therapies. And the potential for cure or long-term survival is highest in early-stage disease when we don't have these targeted solutions. So there is a huge unmet need for precision therapy in early-stage disease after surgery when there is potential for therapy to actually be curative. Now, adjuvant therapy has certainly been studied in the early stage setting. Randomized trials have shown that adjuvant cisplatin-based chemotherapy results in increased disease-free survival and overall survival. When we look specifically at stage 1 patients, however, we don't see this benefit. However, we know that 30% of these patients are not cured in the operating room, likely as a result of occult distant metastases at the time of surgery. So conventional staging criteria are just not able to tell us which of these patients with the smallest tumors are at the highest risk. And so when we treat all comers with chemotherapy, we don't see a benefit in these randomized trials. Staging alone is just not sufficient to stratify risk and identify which patients will most likely benefit from chemotherapy in the adjuvant setting. The National Comprehensive Cancer Network, which creates evidence-based guidelines that inform clinical practice in the US, knows that the data do not support giving chemotherapy to all early-stage patients. But they also know that 30 to 50% of these patients recur and die, so that some of them must be at higher risk to harbor these distant metastases. So how do we determine who is high risk? Well, the NCCN knows that staging is prognostic, so risk goes up with stage. But stage alone is not enough to determine recurrence risk because we still see even stage 1A patients recurring. So the NCCN leaves it up to the clinician to determine if a patient is high risk. And they give some examples of features that could be considered to flag a patient as high risk: poorly differentiated tumors, vascular invasion, wedge resection, tumors larger than 4 centimeters, visceral pleural involvement, and unknown lymph node status. But here's the thing, these are prognostic features, and studies are conflicting to just how prognostic they are, and they have never been shown to be predictive of chemotherapy benefit. Traditional clinical pathological criteria are just not enough. They do not adequately identify those 30 to 50% of early stage patients that are going to recur post-surgical resection. So we really need a better way to stratify risk so that we can identify patients that are most likely to benefit from adjuvant chemotherapy that can be curative, and avoid having all of these patients recur in late stages when treatments are expensive and not curative. Determinar X is a genomic test performed on formalin-fixed paraffin-embedded tissue from patients that have been recently resected for early-stage non-squamous, non-small cell lung cancer. The results stratify patients into low, intermediate, or high risk of recurrence, and physicians can utilize those results to tailor treatment and surveillance strategies. Importantly, the test is performed from FFPE samples from surgical resections, not from biopsies. In the US, the test has been approved by Medicare for patients with stage 1 to 2A non-squamous, non-small cell lung cancer. The test employs highly accurate, clinically reproducible PCR technology to measure the expression of 14 genes. 11 of these are cancer-related genes that have various biological roles in cancer development. Some are transcription factors, cell cycle regulators, or apoptosis signalers. These were identified from a large pool originally consisting of more than 200 cancer-related genes. And in a 361 patient training cohort from UCSF, Cox proportional hazard modeling and other statistical measures were utilized to develop an algorithm. The algorithm combines the expression pattern of these 11 cancer drivers with that of 3 reference or housekeeping genes to create a risk score for the patient. The test measures RNA expression, not DNA levels. And as a genetic counselor, I've often told my patients that whereas DNA can tell you what might happen, it represents a propensity to develop cancer, and DNA mutations can lead to cancer development. RNA expression, however, tells you exactly what is happening in the tumor right now. It's a direct measure of biology and disease behavior. The Determinar X test has been validated in multiple studies, totaling over 1,600 patients, and published in the likes of the Lancet, JAMA, and Clinical Lung Cancer. In a few slides, I'll review the data that is presented in some of the clinical validity and clinical utility studies. We launched the test here in the US in February, and we have since seen adoption of the test across the US with multiple major hospitals and medical systems. I won't say that it hasn't been a challenge getting out to medical offices and communicating the value of the test during the COVID lockdown. It definitely has been a challenge since so many practices here pretty much shut down for several weeks, and now we're finally seeing surgeries being performed at a regular rate again. But the fact that we've been able to gain so much adoption, even during this time, is really, I think, a testament to the value and utility of the test. As physicians here in the US have started utilizing the test and offering it to their patients, we've gained some enthusiastic supporters and have a growing group of key opinion leaders who are out educating their colleagues about Determinar X. I'd now like to shift to discussing some of the data and clinical studies supporting the test. As I mentioned, the assay was developed by analyzing the RNA expression of more than 200 cancer-related genes in a 361 patient training cohort from UCSF. The training cohort included all stages of disease so that it was inclusive of all types of biology, with the goal of training a really highly robust discriminative assay. The 14-gene algorithm was developed from this training cohort and then completely locked down, including the cutoff points. The algorithm was then independently validated in two different cohorts, one from Kaiser in Northern California, and that cohort included 433 patients with stage 1 disease, and a cohort from the Chinese Clinical Trials Consortium, consisting of 1,006 patients with stage 1, 2, or 3 disease. These were independent blinded validations, so there was no going back and adjusting the algorithm so it validates. This was really the strictest methodology possible. The Kaplan-Meier curve on the right represents the Kaiser cohort only, but the curve from the Chinese cohort is nearly identical, showing that Determinar X high-risk patients have significantly poorer lung cancer-specific survival than do intermediate-risk patients and low-risk patients, respectively. And these assay development and validation data were published in the Lancet. A subset analysis of the same Kaiser and CCTC cohorts were published in JAMA. And this sub-analysis looked at patients with very tiny tumors, less than 2 centimeters, which corresponds to stage 1A1 and 1A2 by the 8 staging criteria. And here we're still seeing that same separation in curves, meaning that the Determinar X test can identify patients who are at high risk for recurrence and death, even in the very earliest stages of disease. In fact, about a third of these patients were found to be high risk, demonstrating that even these very tiny tumors can still have high risk biology. This treatment stratification study, published in Clinical Lung Cancer, looked at a separate population of 100 stage 1 to 2A patients who were resected at UCSF and prospectively followed after receiving the Determinar X test. For the purposes of this study, test identified high and intermediate risk patients, and that made up about half of the study population, were grouped into one molecular high-risk group, compared to the other approximately half of patients that were deemed low risk by the test. This was not a randomized trial. The high-risk patients chose whether they wanted to undergo chemotherapy or not. The high-risk patients who did not receive adjuvant chemo had a 48.9% 5-year disease-free survival. The high-risk patients who did opt for chemotherapy, however, had 91.7% 5-year disease-free survival, which is right up there with the 93.8% disease-free survival of the low-risk untreated patients. And these same significant difference in survival between low-risk and high-risk non-treated and high-risk treated persisted when the study population was extended to 200 patients. And that was data presented at the 2018 World Conference on Lung Cancer. The investigators wanted to compare the risk discrimination of the Determinar X molecular test to any risk discrimination provided by the NCCN high-risk feature examples. So these again are poorly differentiated tumors, vascular invasion, wedge resection, tumors larger than 4 centimeters, visceral pleural involvement, and unknown lymph node status. So in the curve over here on the right, a patient only had to have one of those high-risk features to be considered NCCN high risk, and patients were NCCN low risk if they had none of those features. And while there is some initial separation, because these factors are at least somewhat prognostic, the curves eventually collapse and the p-value is not significant. This is in comparison to the curves on the left, which show disease-free survival between Determinar X high-risk patients versus low risk. And here you see a definitive maintained curve separation and a significant p-value of 0.006. So Determinar X clearly performs better than these clinical pathological criteria in assessing risk. And in fact, 48% of Determinar X high-risk patients were actually misclassified as low risk by NCCN criteria. And untreated Determinar X low-risk patients had better survival than untreated NCCN identified low-risk patients. So Determinar X is simply a better way to assess risk and identify treatment strategies. Physicians are actively utilizing this test to make treatment decisions. In a physician survey, and these were 58 physicians treating 120 patients, it was found that 34.9% of patients for whom no chemotherapy was initially recommended actually had chemotherapy recommended after the Determinar X test, based on the results. And among patients for whom chemotherapy was initially recommended, the recommendation was actually changed to no chemotherapy in about 20% of patients. So overall, the test led to a treatment recommendation change in about 1/3 of patients. So physicians are finding the test informative for managing their early stage patients. All right, so remember Miss L. She was, by all appearances, a stage 1B low-risk patient who had a complete resection, but ended up having a recurrence of disease 6 months later. A tragic story that we're all too familiar with. But there's actually more to this story. This patient was resected at UCSF and given the Determinar X test, and her result was high risk. She returned to Asia and had a video visit with the UCSF medical oncology team, who recommended 4 cycles of adjuvant chemotherapy. But her medical oncologist in Asia did not agree with this recommendation, and the patient elected to forego adjuvant chemo despite her young age and excellent health. And unfortunately, 6 months later, she recurred. There are many patients, just like Ms. L, that could potentially benefit from the Determinar X test. For recurrence risk detection, the test has been validated in nearly 1,400 patients, stages 1 through 3, to distinguish between low, intermediate, and high risk of recurrence. Prospective data has demonstrated that the test is predictive of chemotherapy benefit in very early stage patients, stage 1, 1A, 1B, and stage 2A. And it is reimbursed for this indication by Medicare in the US. And finally, there's a role for the test in actively managing patients that had recent resections. The physicians we work with are going back up to 3 months to test previously resected samples to identify any of those patients may be eligible for chemotherapy. And some doctors are going back as far as a year because they believe the recurrence risk information will help them adjust management and surveillance decisions. It is a novel test for early stage lung cancer, and there may be several ways in which it could help patients in your practice. In summary, 30 to 50% of patients with non-small cell lung cancer do not have long-term survival post-resection, often due to recurrence at distant metastases. The benefit from adjuvant chemotherapy increases with increased risk of recurrence and death. And we need a better way to identify those patients likely to harbor those occult metastases and who are most likely to benefit from adjuvant treatment. Determinar X has been validated in multiple independent studies to provide this improved risk discrimination, and in a prospective study has been demonstrated to be predictive of adjuvant chemotherapy benefit. This is a list of peer-reviewed publications about the test. And since we have some time, I'd like to quickly walk through a couple of case studies in which Determinar X was utilized to inform treatment strategy, and then we can go to some questions. So first we have Mr. B. He's a 74-year-old male with an instantly found 3.0 centimeter mass in the left upper lobe. His past medical history was significant for coronary artery disease, hyperlipidemia, hypertension, and prostatic hyperplasia. So he was on a few different medications. In 2014, he underwent left thoracotomy, left upper lobe lobectomy, and mediastinal lymph node dissection. His pathology was low risk, a small tumor with no positive lymph nodes, putting him at stage 1A. However, he was found to be high risk based on the Determinar X test. He was referred to medical oncology, who initiated 4 cycles of carboplatin and Taxol, and Mr. B tolerated the chemo well with minimal side effects despite his age and history of coronary artery disease. And 5 years later, he is disease-free. One last case, Mr. C is a 74-year-old male found to have 3 separate left upper lobe masses. He had had colon cancer in the past and was being actively treated for several conditions, including hypertension, hypercholesterolemia, and GERD. He was a 30-pack a year smoker. Mr. C's pathology revealed at least one NCCN high-risk feature, and he was staged at 1B. He had low-risk results on the Determinar X test. He was recommended for observation only, and 2 years later, he is doing well with no evidence of recurrence. So just a couple of case studies highlighting how this test is being utilized in clinic. And that's all I have prepared.